Hi, everyone. Welcome to our webinar tonight. I'm Callie. I am currently a second year resident in pediatrics at Cincinnati Children's. I'm going to let Shelby introduce themselves as well.
Hey guys, I'm Shelby. I am a first year emergency medicine resident at University of Rochester in upstate New York. Nice to see you guys.
So we are going to talk tonight about kind of a couple of things. One is kind of going to start off by talking about what to do if you didn't match, which I know is kind of a heavier topic. And especially for those of you, there might be some people tuning in who haven't gone through the match process yet and might be nervous about what happens if they don't match next year. Or this might be for some of you who have recently just gone through the match process and have kind of gone through the unfortunate time of finding out that you don't match. And let me first off say that this year was super competitive. In particular, I've talked to tons of students kind of all over the country, some that are international medical graduates. It was just a really tough year. And I think doing things virtually has been really hard. So I want to encourage you right off the bat by saying you are not alone if you did not match this year. And we are going to talk about things to do over the next year to help you prepare to be super successful with the match next year, as well as tips for step 3. So whether you fit into both of these categories that you didn't match and haven't taken step 3 or one or the other, hopefully you will find this really helpful tonight. So we are going to talk a little bit just right off the bat about kind of who we are here at Blueprint. So Shelby and I are both tutors for USMLE exams. So that's something that we are both really passionate about and something that we offer through Blueprint. So we do one-on-one tutoring online for USMLE exams, COMLEX exams for DO students, shelf exams, even like your medical school exams kind of early on in your first and second year. So if that's something you're interested in, we can definitely kind of get you connected offline to talk about things like that. The other things that we also help with is Cream Fighter study plan. So you can do a free trial, and we'll talk about this a little more later. But that's a great way to kind of get you a great study schedule that is built for you, that is personalized, that'll help you kind of stay on track and stay focused throughout your studying period. And then we also do other kind of residency consulting. We have Roche Review, Q-Banks for kind of throughout your medical career. So there's lots of things that Blueprint can offer to help you. But we just kind of wanted to say right off the bat, that's who we are and what we do. But Shelby and I in particular do a lot of tutoring. And so that's why we're really passionate about talking about how to study for step 3. So what we're going to cover tonight, so like we talked about, we're going to cover what to do if you didn't match. We are also going to talk about tips for optimizing your gap year, if that's something that you're going to be doing in this next year, if you didn't match. And then at the end, we're going to talk about specifically things that you can do to help study for step 3 and kind of put your best foot forward for that exam, because that's something you can really do to highlight, your strengths and kind of give you a one-up on your application for the next year to help you be a little bit more successful. So we're going to talk about that test in a little more detail and specifically talk about the CCS cases, which are often a stumbling block for those taking this test. So I'm going to let Shelby kind of take it away now and kind of talk about what to do if you didn't match.
So just to reiterate something that Callie said earlier, this was a really, really difficult year for the match and in the SOAP, especially with everything going on in the world right now. There's a huge number of applicants vying for a very limited number of positions. COVID is still happening. Virtual interviews are still happening. Like it's really affecting this whole process. So we definitely feel for you guys. And we went through it last year and the year before. I did virtual interviews for mine. Callie, I don't think yours were virtual, right?
No, just all my fun stuff. My match day and graduation were virtual.
Yeah, same. So like dealing with a virtual match day, a virtual graduation, like virtual interviewing, it's just all very, very challenging. And it's not ideal, and we have had kind of like to adapt and change our mindset about certain things. So we just want to reassure you guys that like all of the feelings that you're feeling right now, if you didn't match, are perfectly valid. And this is certainly a safe space to feel those feelings and ask any questions that you have. Zero judgment zone, none of this is anyone's fault. It's just the way that the system works. Sometimes certain people don't get the positions that they want, but there are certain ways that you can get to those positions. So if you're looking in particular for an unfilled position in this year's match, there's a few different ways that you can go about it. NRMP maintains a list of all of their unfilled positions. And the Find a Resident website is actually a website run by AAMC, and I'm just going to drop that link in the chat for you guys here. This is a really great resource to use. So it helps you to find open residency and fellowship positions through the NRMP match. So if you were unsuccessful in this year's match, or if you're currently in a residency program and you want to switch specialties or switch locations or switch programs or something like that, you can also do that. And this is open to international medical graduates, current residents, fourth-year medical students, all of the above. So anyone can use this site to either find a new residency program or find an unfilled spot in a program. And then there's another kind of similar site called Residency Swap, and I'm going to put that in the chat as well. So this is another website. It's not through the AAMC, but it is a list of all of the current vacant residency spots and positions outside of the match as well. So this also includes some anonymous spots of current residents that are trying to give up their spot, so they can anonymously post these on this website so that they don't have any issues with their current program. So this is another way that you can kind of look for some of those open spots. And they even have like a couples match mode. If you and your partner are looking for spots in the same area or the same program, you can kind of like couples search with your partner. And then there's also just the tried and true method of asking all of your contacts. So anybody that you know, mentors, former faculty members from your medical school, current residents, former residents from programs that you want to go to, people in the specialty that you're trying to apply to, using and working all of your contacts can be super, super helpful here. So just literally throw it out there. A lot of people are using Twitter nowadays to do this, which is a huge, huge resource. I've seen tons of people get positions through Twitter. Facebook, Instagram, like all of the above social media, use it. I mean, you can totally use it to your advantage to network and find people who have open spots for you. So those are just some places that you guys can look for some of the unfilled positions this year.
Yes, I totally echo the Twitter. If you are not on Twitter, definitely get on there, because I mean, I get like notifications just to my phone, like from other med Twitter things. And I've seen tons of people talking about residency spots that are open, or also just kind of other opportunities of, things that you can do in this year to help you match next year. So that's a great place to look. If you don't have a Twitter, would recommend getting one, if for no other purpose than to help you during this time.
You don't even have to post anything. Just use it to like lurk opportunities.
Yeah, exactly. So the next thing we're going to kind of talk about is big picture is, if you didn't match, and let's say you're not able to find kind of another spot through one of these other avenues, like we just talked about, what things should you be spending your time and efforts kind of working on during this time prior to September, when you will need to apply again? So biggest thing I can recommend kind of out of all of these things, of course, there's lots of strategies, and depending on who you are and what you think some of your kind of pitfalls are in your application, you can kind of tailor these recommendations to yourself. But big picture is the main thing you can do is kind of figure out where you might have some weaknesses in your application and try to enhance those in any way possible. So that could be a lot of things, right? So that could be maybe your personal statement was, you had to kind of rush to get it together and maybe didn't have a lot of people to look over it. So, you might want to just redo your personal statement. You might have low board scores, which I feel like that is often a very common thing that I think people feel like is a weakness for them. And, of course, unfortunately, with the USMLE exams, once you take it and pass it, you can't go back and, make yourself get a better score on them. However, I think something that is often underestimated is you can try to take step 3 if you haven't taken it yet, and you can blow that out of the water. We can help you, do really well on that. And that's something that looks really, really good, that, hey, I might have struggled on step 1 and step 2, but look how great I did on step 3. And I think Shelby and I can probably both say that as you go along in your exams, they get more and more like clinically applicable in terms of, what you actually use as a doctor day in and day out. And so I think having a good step 3 score, while for, some things like fellowship, people argue it's not as important, for getting into residency, if you have a good step 3 score, I think that's a really great thing that you can highlight. The other thing about low board scores that I will just kind of mention here is, it's not something that you need to like feel like you have to, belabor in your personal statement or anything like that. But I think it's totally okay to address it head on. And I think a lot of people who have low board scores, there's a myriad of reasons why that could have happened. But like, if you're somebody who had like a really rough year that year, a lot of family things, like it is totally okay to admit that you are human and that you struggled with something. And honestly, I think, addressing it and just saying like, hey, this is what I've learned from that experience. I went through a lot during that time, or maybe you have really bad test anxiety or whatever it may be. I think it's totally okay to address that head on and show like, I always kind of try to tell people like, you don't want to be at a residency program that doesn't, see you as a human and as an individual. And so, it's okay to let those things show in your application, and just highlight all of the other great things you've done. You are more than just a number on a piece of paper, and you want to go to a residency program that sees that. So don't be deterred, and think that, all residency programs are just going to count you out if you have a low board score. So really just kind of sit back and reflect on some of those things and you can ask advice from, there's plenty of residents out there that'd be more than happy to look over your application. Other attendings, mentors, anybody you have them look over your application and see if there's any, weak areas and things that you can enhance. Other things, kind of talk to advisors, deans, mentors, anyone, and just kind of ask them, tell them about your strategy for applying this past year and what you're thinking for the next year. Sometimes they might have advice on like very specific programs who take applicants, are known to take applicants, from different parts of the country or different parts of the world, or applicants who, might have struggled on step 1, but this program, they're really okay with that because they just want to see that you're a good, well-rounded person. So talk with people about different programs and try to strategize where exactly you're going to apply. And then we kind of already talked about this, but I really think, step 3 is a huge thing that you can do to kind of, boost all of this if you haven't taken it yet. If you've already taken it, great. You can still boost some of these other areas. And, and some of that might be getting more clinical experience, doing more research, things like that. But really, if you haven't taken step 3, I think that's a great place to, use your time now to study for that and do really well on it. And then that can help you put your best foot forward when you get to application season.
So kind of along those lines, we have some suggestions for different kind of categories, different buckets of things that you can improve when you're working on your application for next year. So the first one that everybody thinks of is, how do I get more clinical experience? Because you want to kind of stay in the medical realm so that you don't lose your skills, so that you keep up with your contacts, so you don't forget how to like talk to patients. Because if you take a whole year off, it's kind of rough to like go back into it. So things that you can do to get more clinical experience while you're waiting to reapply. Ideally, it would be something involving the field that you want to go into. So a lot of these are kind of like emergency medicine oriented, but you can certainly find positions in other fields too. Scribing is a really, really great opportunity that you can do. Emergency medicine has a lot of scribe positions available. There's a lot of different companies like Scribe America and Team Health and stuff that do scribing. But there's also tons of other settings where you can be a scribe, like physician offices or like, other things like that. So it doesn't have to be in the ED. But if you do work in the ED, this might be like my personal bias coming through. But you will see like all different types of patients, and it'll be really good preparation for pretty much whatever field you want to go into, even if it's like derm or neurology or something. You will see all of that and more, much more than you ever wanted to see in the ED. Volunteering is an EMT, so you can either be like a volunteer EMT firefighter, or you could even like go back to school. It's like a 6-month program to become an EMT basic, and then you could actually get paid to do it, which is really great. So this is something that I did. I actually did both of these things before medical school. I was a scribe in the ED, and then I became a paramedic before med school. So can definitely vouch for both of these opportunities. They're really, really fantastic clinical experience. Even though they are very EM oriented, you can certainly make applications to any other field of medicine. Observerships are another way that you could kind of work with physicians in the field that you really want. So maybe if you want to do like radiology or radiation oncology or just something a little more niche, you could work with a physician in that field, kind of just like an unpaid shadowing experience. But this can also help you to get letters, and it can expose you a little bit more to the field and help you make sure that this is the field that you actually want to go into. And then, of course, there's volunteering for medically related organizations. Doctors Without Borders is a huge one, Planned Parenthood, free clinics. There's a lot of different opportunities, so you can look into whatever your local opportunities have to offer. But volunteering your time is a really great way. It's kind of like a dual purpose. It shows that you're invested in your community, but you're also invested in taking care of patients and working in the clinical setting. In terms of research, the biggest advice that I would give in this area is only do research if you're truly interested in research, and that is like something you actually want to do. Because I know a lot of students ask about, well, do I need to do research, and should I do research in my chosen field? And there's certain specialties that really, really prefer you to have research experience. Like I think a lot of the surgical specialties, OBGYN, general surgery, they like for you to have research experience. But not all specialties really care about that so much in their applications. Like emergency medicine, for example, doesn't really care that much about research. So if you have it, it's great. Like no one will ever get mad at you for having research experience. But if you don't have it, no one is going to fault you for that. And they're much more interested in other aspects of your application. So it's good to kind of know what the typical application profile is for someone applying to this specialty. And if you're like really interested in research, then definitely do it. A good place to start would be the hospital where you did your clinical rotations at. So some of the attendings that you may have formed relationships with, some of the residents there, I guarantee you many of them have ongoing research projects because it's a requirement for every single ACGME certified residency program to have a research project. So every resident has to do one at some point. So I guarantee you'll be able to find a resident who's doing one and would love to have a medical student or a post-medical school student helping them with their project. And that could potentially get you a publication that you can then put on your next application. And then there's also these research fellowships too with different residency programs.
Yeah, and I will say just one other little plug there is that I think something else that you can like use this time for. And again, like I know if you're like reapplying in September, like you kind of have, March to September, but I think it looks really good. And this kind of goes for just applications in general, to have things that are like longitudinal that like show you are like invested in things. So like if you are planning on trying to get more clinical experience, like find something, like a local free medical clinic or whatever you want to do, find something and just kind of stick with it, stick with it through this time. And I think that shows like a lot of, you're not bouncing around from thing to thing, just trying to like add things to your CV. Like, I think that shows that you're like really invested, like we said, like in your community and taking care of like the same population of patients consistently.
Yeah, 100% agree with that. It is really important to show that you're committed to whatever you do choose. And if you maybe try to pick like one or two of these categories to focus on, depending on what you perceive your own application weaknesses to be or areas of improvement, then pick one or two of those things, but don't try to do it all. You can't, focus really hard on studying for step 3, but then also volunteer 10 hours a week and have a research job and work in the clinic. Like you just can't do it all. You're going to stress yourself out. And, the goal is to make yourself a better applicant, but not drive yourself crazy in the process. You're going to work a ton in residency. So don't overwork yourself right before residency, because you don't want to enter residency stressed. We talked a lot about volunteer experience, so I won't belabor that too much more, but you could, of course, look at local homeless shelters, soup kitchens. Like there's tons of volunteer opportunities everywhere. You really just have to, again, you can use social media to look for volunteer opportunities. There's tons of stuff on Twitter, and then just any sort of like local community events, wherever those are posted. And then in terms of academics, so we already talked about taking extra time to improve your score on step 3. So that's what we're going to kind of focus on for the second half of the webinar. So we'll talk about that more. Some people choose to do an additional degree like an MPH or an MBA. So this can be a really great option. Some schools even offer this for free to their students who don't match. So I graduated from St. George's University in Grenada. And if students there do not match, then they will let them do a master's program. Tuition is covered for them. So some schools will actually offer that for you to help you boost your application for the next year. So see if your school offers any sort of opportunities like that. In terms of your letters of recommendation, it's really nice to have new ones. They really prefer for you to have new ones that pertain to your most current clinical experiences because they want to see how you've grown since medical school, what you've done to improve your application. And, chances are whatever you submitted before was fine, but it also applies to the you that applied last year. And hopefully you're going to be kind of like a new and improved you in your application this year. So you want new and improved letters to go with that, all of your shiny new experiences. And then you can even rewrite your personal statements if anything changes. If you come up with something, that speaks to your experience a little bit more, you might even write about, the struggle of having to reapply and how that made you kind of like reevaluate things and how this has made you even more sure that this is the specialty you want to go into. You can really use all of those struggles to kind of pour that into your personal statement and make it a little bit more just like, this is where I want to be. This is how I've worked hard to get there. And they love to read stuff like that.
Awesome. So now we're going to kind of segue into talking about a little bit more about step 3. Something that, the classic thing I always heard in medical school was you need 2 months to study for step 1, 2 weeks to study for step 2, and then a number 2 pencil for step 3, even though it's on the computer, but basically saying you just show up and take it. I will say for myself and everyone I know that has taken it anytime in the recent past, that is definitely not the case anymore. It is a very doable exam, but don't just show up and take it and know nothing about it. You will likely not do fantastic. You might be able to pass, but you should probably take some time to actually study. We did get a question in the chat that I just thought I would kind of throw out here for everybody about step 3. Somebody asked if step 3 is doable without residency, and it most definitely is doable without any residency training. I will say there are some things that I was happy to have had a little bit of residency under my belt to take this exam, mainly for the CCS cases, I would say, because, and we'll kind of go through some practice CCS cases at the end, but one of the big advantages to having some clinical experience of doing admission orders and things is for those cases. However, if you study them, and we'll kind of go through how to study them, properly, you can most definitely take it without any true residency time under your belt. And you can take it really any time after you graduate. I would say if you did match, I probably would wait and take it on an easier, lighter month during your first year of residency. Some people even wait to their second year. It kind of depends on your specialty and your program. But you definitely can take it prior to being in a residency program, as long as you study properly. So definitely kind of our tips for not underestimating this exam is making sure you give yourself enough time to prepare, and that looks different for every person. If you're going to be doing lots of clinical time or lots of research, or you're starting residency and you're trying to take this exam, you might need a couple months to study because you're only going to have a few hours to study every day, versus if you really aren't doing a whole lot of other things that occupy your time, you could study for this over the course of a month if you really studied every day, but just make sure you take enough time to prepare. Avoiding resource fatigue. I think this stands true for all of the step exams, making sure you're not using too many resources. Usually, especially for this exam, I think less is more, and we'll kind of talk about some of those resources here in a minute. Definitely dedicating time to study for the CCS cases. So they are very unique. Somebody just asked what CCS stands for. So they're computer-based case simulation. So it kind of, we'll give some examples at the end, but it basically is almost like a standardized patient that you would see, probably throughout your medical school training, in a clinical setting where you go in and you get a history and a physical exam, and then you would decide what tests you want. It's all like that, except it's simulated on a computer, and you don't physically see the patient. It just tells you what your exam findings and your history is. Definitely make sure you utilize practice questions. UWorld is still going to be your best friend. Unfortunately, you're gonna buy it and pay for it one more time around. But then after that, you might be set until you're doing your other board review questions for whatever specialty you're doing. And then biostatistics is huge for step 3. Comes back to haunt you from both step 1 and step 2. So definitely make time to review biostatistics if it's something that you kind of temporarily study for the other exams and then kind of let go back into the cobwebs of your brain. So it's a huge part of the exam. It's only on day 1 of the exam. So that's the other thing I'll say is step 3. For those of you who might not know, it's a 2-day exam, which is a little bit different. So the first day is all just multiple choice questions. And then the second day is half of the day is multiple choice questions and half of the day are these CCS cases. But the biostatistics portion of the exam is all on the first day. So you'll only see biostats questions on the first day, which is kind of nice. You can just focus on that day and then kind of push it to the side for your CCS cases on the second day of your exam.
So in terms of establishing your timeline for this exam, this really goes for any exam, step 1, 2, and 3. So you've probably heard a lot of these things before, but don't leave your test date open-ended. It's really important to just schedule a test date and stick to it. And that way you can make a realistic study schedule with that date in mind. Sometimes people get freaked out the closer and closer they get to their test date and they start wanting to push it back and push it back. And they're like, oh, I'll just push it back a week and oh, I'll just push it back another week. And the further you push it back, sometimes you pass your peak of knowledge and then you kind of start on the downslope. So it's really better to take it when you're like right there in that peak of study time. So like Callie was saying, choose a light rotation during residency or, during your gap year, if you choose to take it at that time. Make sure that you have relatively no other commitments so that you can do kind of like a mini dedicated like you did for step 1 and maybe step 2. And just like choose a date and leave it at that. Do be realistic about when you'll have the time to study, meaning, don't try to do it in the middle of your ICU rotation in residency, or, don't do it when you just signed up to write this huge research paper. Like you have to have dedicated time set aside to do these questions. There's quite a few questions on UWorld, and then these cases do take a bit of time themselves. And then we always recommend that you do every single case that's available just to give yourself the best chance of seeing everything that you could possibly see on this exam. Some people give themselves a day between their test days. I didn't actually know that was a thing. Can you actually give yourself do the questions on one day and then take a break and then do the cases the next day?
Yeah, I'm pretty sure you can take up to 2 weeks actually in between them, which I would not recommend taking that long. But yeah, so you can take time in between your test days. It really depends on your Prometric center, what days they offer it. I know for me personally, between my work schedule and the days that Prometric was offering it, I ended up having to take it back-to-back days. It would have been really nice to have at least a day in between, but you can do it back-to-back if that's your only option. But most people will take at least a couple days actually in between, which is really nice.
Nice. For me personally, I think I would prefer to just take it boom, boom right away. So I'm currently studying for it now. My program actually doesn't pay for it until you're in your second year. So that's another thing to consider too, is does your residency program help to supplement the exam fee? And if so, when is that in your residency? So that's also a good question to ask when you do match. And then incorporating practice tests is going to be super important. So this also goes for step 1, step 2. You've heard all of this before. Practice tests, you have to practice like you're going to play. So make sure that you're doing some timed blocks in addition to your tutor mode, and just making sure that you still got the stamina to take a very long exam. Because I know my step 1 stamina was really, really high, and now that I'm in residency and I haven't been doing as many questions as I did in medical school, it's definitely gone down quite a bit. So I really need to work back up to being able to do a couple hundred questions a day for sure.
And here we'll kind of put in a plug right here for cram fighters. So this is kind of what a sample study schedule would look like if you were to, kind of make a little mini dedicated period for step 3. So there's roughly, I think, like 2,000 to 2,500 ish step 3 questions. And honestly, UWorld is coming out with new ones all the time. So Shelby, you might know even better than I do how many there are currently. But you can kind of, divide your questions over the course of a couple weeks. Make sure you're doing CCS cases, which they have practice cases on UWorld. So you can do, one a day for for 1 week, and then kind of ramp it up to 2 to 3 today and make sure you do all of them. And Cream Fighters is great for making study schedules. We kind of talked about this at the beginning, but that is a great resource. And I highly recommend, if you're getting ready to start your step 3 studying, you can do the free 7-day trial for Cream Fighters, where it will do all of this for you. So it takes all of the guesswork out of it. You will set what your exam day is, and it will tell you what you need to do every day to make sure you're staying on track to getting everything done you want to get done before your exam day. So that's a great resource as well, that we are happy to kind of hook you up with the people to talk to you about that if you are interested.
So just some general tips. Sorry, I'm trying to copy and paste this link in here for you guys. So ccscases.com has a bunch of different cases that you can use for practice. And then you can also do the UWorld. They have interactive cases as well. So try doing like 1 or 2 of these per day as you start your study schedule, and then you can kind of ramp it up as you get closer and closer to your test. It's really important to be doing these regularly though, because like Callie said earlier, these are the things that kind of tend to trip people up, especially people that haven't started residency yet and they're not used to putting in orders and like order sets and admitting patients and things like that. It's just a little, you have to learn the software and learn kind of the process of what to click and things like that. So it's kind of like really getting you into that clinical mindset. Maintaining a good differential diagnosis is really key. So even if it seems like a very, very obvious diagnosis on the case, it's good to think about other things because that's going to drive how you're ordering your labs, just like it does in clinical practice. So if I have a patient who comes in the ED and I think that this is definitely costochondritis, like there's no way that this person's having an MI, I still have to order the cardiac workup. I still have to order, we're going to think about a CBC and a BMP and troponins and EKG and a chest x-ray, because we have to make sure that we're ruling out all of the things that are higher up on the differential, the things that are potential badness that we need to rule out. So always maintain that good differential. You'll know pretty quick how sick a patient is. So something that they teach you in like EMS is, sick or not sick. You kind of lump the patients into 2 very basic buckets. Is this patient sick or is this patient not sick? They're going to be sick in some way, but some are going to be like critically ill, and that'll be very apparent based on their vital signs, based on the way that they're described in the vignette. So just kind of getting a feel for how sick this patient is and how deep you need to go in their workup is going to be really important for these. Just little things like if you're considering that this patient might need surgery, if you think they're going to need an appy or something like that, don't forget to make them NPO. So that these are just like kind of little style points, and getting pre-op labs, so coags and pipe and screen and things like that. These are part of a lot of order sets on the EMR that you'll see when you actually start residency. But if you haven't started yet, this stuff might not quite be second nature to you yet. So you kind of have to think about it. And then counseling patients is a huge one. So for our medicine and family medicine colleagues, like this is bread and butter for them, but sometimes we don't always do this in the ED. So I really have to think about this one personally. But counseling patients on whether it's, smoking cessation or safe sex practices or diabetes education, just like little things, counseling will get you points. So don't forget to do it.
All right, and we kind of already dropped the link for CCS cases here in the chat, but this is an extra website outside of UWorld that you can use to get extra cases. So I was actually in the process of responding to somebody in the chat about this. But UWorld, just so everybody knows, UWorld, what comes with like the UWorld subscription in terms of CCS cases is there's practice cases, and there's about 50 of them, if I remember correctly, that are what they call practice cases. And those are just cases that you kind of read through. So they're not timed. You're not manually typing in orders. They're just kind of giving you a setup of like, hey, if you saw this type of patient on your case, these are the types of tests you would order and things like that. And then they have their interactive cases. And I think there's about 30 or 40 of those as well. And those are the ones that are like the real exam where you type in the orders. It's, the interface, it looks like what it does on your actual exam. So there's a decent number on UWorld, and some people feel totally comfortable after they go through all of the ones on UWorld and feel like they're ready to go. But if you want some more practice, because these can't, especially if you're somebody who feels like you're not as comfortable with, thinking through all of the types of orders and, like just physically typing them in, ccscases.com is a great other resource that has way more cases, has 101 cases on there to choose from that you can kind of practice. And they kind of will actually score them and give you feedback versus UWorld. It'll tell you what the right answers is, but it doesn't give you a score on your cases. So some people find this to be really helpful, and you can try out 2 free cases before you buy it. So I would recommend doing the UWorld ones, but if you still feel like you need more practice, this is a great option. All right, so now we're going to jump in to actually going through some of these cases. So for those of you that have not done any of these before, these are very, very abbreviated and kind of very straight to the point versions of these cases, but it'll be really helpful to go through. So I'm going to do the first one, and then Shelby is going to do the second one. So it would be great. I always love when we do these cases, if you all in the chat can type out kind of like your thoughts, if you have any questions, and I'll kind of ask you guys some questions, so it's a little bit more interactive and kind of helps you think through things. So this case that we're going to start with is a 23-year-old female that's presenting with right lower quadrant pain that started 3 hours ago. The pain initially started at her umbilicus and then later migrated to her right lower quadrant. She also is having nausea, vomiting, and chills. She has no significant past medical history aside from smoking a half pack per day. So I will say this is pretty true to what your little, like when you're on the exam, you'll have the case pop up. And it'll give you a little HPI type section like this. And this is pretty true. Sometimes they'll give you some more information. Sometimes they'll give you a little less. But a lot of the times the diagnosis is, I would say, 90% of the time the diagnosis is usually pretty obvious, either from the HPI or from the physical exam. So in this case, just right off the bat, I'm sure a lot of you have a differential in mind, but if you want to type in the chat kind of what you're thinking this might be, or what labs or imaging you might want for this patient. I'm seeing some great stuff. I saw some people say CBC, a CMP, pregnancy test, fantastic. In any, woman of childbearing age, you should definitely think about that, especially with belly pain. Some like STI screening, abdominal ultrasound, great. Great. I'm seeing differential. People are saying appendicitis or ovarian torsion. Could be like a kidney stone that's kind of on that right side. Fantastic. Those are all great things to think about. So like I said, many of these cases are very straightforward, but the key is to learn how to use the software and how to obtain every possible point that you can on these cases. So we are going to talk about what some of those things are. So we already talked a little bit about things that you guys would order. And I think everything that everyone has said thus far is fantastic answers. Other things that I saw added to the list are like a urinalysis and urine culture. And I think that's totally appropriate as well. So you always want to rule out the big, bad, scary things. In this case, I think, you're probably 2 most severe diagnoses that are can't miss diagnoses. And Shelby can correct me since that, in the ER world, we have 2 things that we always think about, and ovarian torsion is one of them and appendicitis is the other. And those are ones that you cannot miss. So Um, Making sure that you order your labs is important. Ordering your imaging is important. But also for this exam, you have to order your physical exam, which sounds rather strange. But you physically have to go through and click which systems that you want to examine. And in general, like we kind of put here, the big four is your general appearance, your heart, your lungs, your abdomen. For every single patient, doesn't matter what they're coming in with. And Shelby probably does this in the ER. You for sure do those four things every single time. In this patient's case, doing a genital exam and possibly like a bimanual exam is probably important. So you would do a genital exam in this case. You might want to do HENT, make sure there's nothing else going on in the head and neck area that might be kind of causing, any other symptoms. Do a skin exam, see if there's any rashes, anything else that might lead you to believe that there's one diagnosis versus another. So those are kind of the things that you could do in this situation. I'll just say in general for the physical exam, and this is a question I get a lot with my students that I tutor for step 3, is like, should you ever just like click all of them? Like, is it ever wrong to click all of them? And the answer is yes. If you have a patient that comes into the trauma bay, and is like, had a motor vehicle accident, I can almost assure you that Shelby is not doing like a full like genital exam, rectal exam, and initially you might do that later, but you want to do the kind of most life-threatening and easiest things to do physical exam wise. So those would be situations where you won't do everything, and it might be actually wrong to do everything. But if it's a patient that's in clinic or is medically stable, I would do all of the things plus minus like genital and rectal exams, because some patients just don't need those and those are uncomfortable. But otherwise, you can probably do most things on a stable patient. And then we already talked about a lot of this, and you all did amazing in saying the things that you would order. So CBC, looking for infection. CMP, kind of looking at, could this be liver? Could there be electrolyte derangements? PTINR, looking at not only your liver function, but also assuming that you might be going to the OR with this patient, you might want to get some coags prior to doing that. A blood culture, because this patient has been febrile and has been sick, and they could have bacteremia as well. You would definitely want to get a pregnancy test, especially if this patient is going to be getting any meds that might be teratogenic or not the best during pregnancy, or might be getting any imaging coming up that you would want to know if the patient was pregnant before radiating them. And then a UA to make sure that they don't have a UTI going on that could be causing some of these symptoms. And then totally agree with everyone who was concerned about both appendicitis and ovarian torsion. Those are probably highest things and the things you don't want to miss on your differential. So you definitely will want to get your abdominal and pelvic ultrasound. And that's the other little plug that somebody was asking in the chat, if you will ever get points off for doing too many things. And I will say, if the too many things you're doing are like little labs, like maybe you didn't really need a CBC, but you ordered one, probably not. You're not gonna fail the case by ordering a CBC, because that's a fairly cheap, benign test. But if you were to get an abdominal MRI in this case instead of getting an ultrasound first, then yes, that would be wrong. So don't always jump to the biggest thing. Try to do the cheapest, most inexpensive, least invasive things first. And that's usually what the right answer is for these cases. And then the kind of miscellaneous things, and these are some of the nuances that, most of us, by the time we're getting around to taking step 3, we're very used to, we know what appendicitis or ovarian torsion might look like. We know, what labs we would order. But some of the things that you have to remember to do on this exam that are a little bit more, clinical, and that's the point of these exams, is, would you remember to make the patient NPO? Like, as soon as they come to the ER, you do not want that patient eating and drinking just in case they need to go to the OR. Would you remember to consult the surgery team? And I will say, sometimes on the exam, you will consult surgery or cardiology or whoever, and they will come back to you and say, actually, continue medical management with you as the provider. And they sometimes don't help you, but you should still consult them anyway if you're concerned about a surgical issue or, whatever other body system you might consult a specialist for. Would you remember to order an IV access, order pain meds? So, this patient might need opioids, or at the very least, some IV Tylenol or Toradol. If this patient's going to go to the OR, would you remember to order pre-op antibiotics? would you order the standard, perioperative labs? So make sure you get your, coags, your type and screen, things like that before, and make sure you have some screening labs afterwards. And then you have to admit the patient. So you would have to say, I'm moving this patient from the emergency department to the floor, or if the patient's really, really sick, they might even need to go to the ICU. And then, in our patient's case, they told us at the beginning that she was a smoker. So even though smoking is probably not directly related to what's going on with her, just sometime before the case ends, you would definitely want to make sure you talk to her about smoking cessation. Other things you can counsel patients on are, safety type things. So seatbelt use, contraceptive methods, preventing STIs, things like that. So those are all great things to remember to talk to your patients about at the end of a case. All right, Shelby's case.
All right, so we got a second case for you guys. So this is another emergency department case. So a lot of these cases come through the ED, which is great if you're going to be an ED doc because you're going to see these people all the time. So a lot of these things are going to be very second nature. It's a little more difficult for our pediatrics colleagues who don't see a ton of adult patients. So just keep that in mind when you're studying and really do all of these cases just to make sure you get exposed to everything. I feel like we cheat a little bit in emergency medicine because we see these patients all the time. So we have a 65-year-old white male who's coming into the ED with sharp chest pain and respiratory distress. So he's in acute distress. He's moaning and he's holding his hands over the right side of his chest. So just based on this 2-line vignette that we have, is this patient sick or not sick? Sick. Yes, this is a sick patient. So he is in respiratory distress. He's got sharp chest pain. We don't even have any vitals yet, but we know that this is a sick patient. So now let's see if they'll give us some vitals. There we go. All right, so we have our initial vital signs. So he's afebrile, 98.6. His pulse is 120 and weak, bad. Respiratory rate is 34, also bad. Blood pressure is 90/60, bad. So he has a lot of badness going on. This is a very sick patient. They also give us his weight, his height and weight, just in case we have to do any weight-based dosing for meds, which we will not need to do for adults usually. All right, so now we get our history. So this patient is here for chest pain and respiratory distress. So he's a 65-year-old accountant. He's brought to the ED by ambulance from the trucking company where he works. Somebody is mentioning that we need an O2 stat, which is really important, and I'm surprised they didn't give it to us, but we might have to ask for it. So 10 minutes after the ambulance arrives, the patient develops excruciating sharp chest pain in his right chest, marked respiratory distress. He's rating the pain 8 out of 10. Increases with respiration. He's not able to answer questions. So he's sounding just sicker and sicker. This should be building a picture in your mind of, okay, this is somebody we need to emergently do something for because he is unstable. So the coworker who came with him to the hospital said this has never happened to him before. The patient has emphysema and asthma. He's had these for years. They had to give him oxygen during transport. Patient is not able to give you any history because he is in respiratory distress. All right, so picturing in our mind kind of a differential for this patient, before we even do the exam, what types of things are we thinking that this patient might have? What diagnoses do we really need to be on the lookout for? MI, COPD exacerbation, pneumonia, MI, lots of MIs, good. Awesome, you guys are putting a lot of great things in the differential here. COPD, good, perfect. So we're taking the patient's clinical picture and past medical history together. Ruptured, okay, so I think we're maybe thinking about a ruptured bleb with the COPD, so that's a really good thought. So giving us a pneumothorax, that's a great thought too. And then Callie mentioned in the chat too, they don't usually give you the O2 sat, you have to order it separately under pulse ox, so that's definitely something we would want to start with immediately on this case. All right. So now we're going to move on to our exam. So remember, you have to order each of these things separately. So on this patient, you really want to take a good look at everything. In real life, you're going to be starting with the heart and lungs on this patient because you want to know, does he have bilateral breath sounds? What does his heart sound like? Does he have JVP? That kind of stuff. So let's see what they're giving us here. It's a lot of kind of tiny text, but bear with us. We're going to go through it. So his general appearance, he's in marked respiratory distress. That's what you need to take away from this. So he's moaning, he's holding his hands to his chest. For his skin, he's pale, cool, diaphoretic. For his lymph nodes, nothing abnormal here. Head and neck, everything looks okay here. He has tracheal deviation to the left and JVD 10 centimeters. Okay, so 2 really big findings there. So all of this, you should be kind of putting this together and picturing this patient in front of you, thinking, okay, what do we need to do for this guy to fix his terrible vital signs and make him a little bit more stable? For his chest and lungs, he has chest wall is normal, so we don't see any trauma or anything. So maybe we're thinking of maybe some sort of traumatic mechanism here. His chest wall looks okay. He has hyperresonance to percussion on the right and no breath sounds. Okay, that's important. So remember when they talk about the ABCs, airway, breathing, circulation, at this point, this is where you stop and you need to do something for this patient. On the CCS cases, it's a little bit awkward. It's not like in real life where you would just do the thing. You have to click all the boxes and, put the orders in and click the things that you would do. But we're already kind of thinking of the intervention that we need to do immediately for this guy. He does have breath sounds on the left, so that's good. For his cardiovascular exam, he is tachycardic, but his heart sounds are faint. We don't hear any extra sounds. His pulses are bilaterally present, but weak. And then we already mentioned the JVD here. For abdomen, that looks okay. We don't see anything abnormal there. Extremities and spine, we don't really see anything abnormal there other than the weak pulses that we already knew about. And then for neuro, he is not able to answer our questions, so we can't really ask him any orientation questions or anything like that. But he's moving all of his extremities. His reflexes are normal, so we can be reassured there. So now, given his exam, what is a little bit of a more narrow differential? Like, what are the things that we're thinking about immediately that we're going to need to fix in this patient? You guys want to throw that in the chat? Pneumothorax. Yes, exactly. Specifically, what kind of pneumothorax? Good, right-sided. Yes, David has it. So this is a tension pneumothorax. So this is a very, very sick patient, and we need to do an immediate intervention or this patient is going to die. So what is the intervention that we need to do immediately? The life-saving one thing that we have to do. Yeah, nice. So needle decompression. Good, you guys are awesome. So we need to do a needle decompression, stick a needle in there, let some of that air out, and get some of the pressure off of his mediastinum so that he can breathe a little better, get the pressure off of his heart so he can circulate. So if we go to the next page, we're going to see some of the orders that we're going to put in. So again, this is kind of like the awkward part where you have to click everything in succession. So obviously we need to put this patient on oxygen and we need to monitor his pulse ox. So those are things that we're going to do. What are some of the orders that you guys want to put in other than the needle thoracostomy, the chest dart? What are some labs that we're going to want on this patient? Once we get him stabilized, of course. Good. So we're going to need a CBC. We're going to need a CMP. We're going to want to check and make sure he doesn't have a big infection, anemia. We're going to check his electrolytes, his kidney function. Good. Troponins. That's a great one. ESR, CRP, maybe. CK, maybe. BNP, BNP, we're going to want because we want to take a look at his heart, make sure he's not having like congestive heart failure exacerbation. So good. Those are all perfect. And then after we do our, you can go ahead. Yeah, you can go to the next one. So a lot of those things that you guys mentioned are on here. So we have our oxygen and it says route here. So just be mindful of that. You're going to have to choose how you want to give the oxygen. So in this case, it looks like they're giving it intranasally. So with a nasal cannula, which is fine for this guy. I don't know what his O2 stat is. So once we found that out, we could maybe adjust that accordingly. We have our troponin, BNP, CBC, CMP. We did our needle thoracostomy, and then of course that's going to be followed up with a chest tube. So we're going to eventually need to do a chest tube for this guy. And then our consults, like we mentioned earlier, we're going to have to dispo this patient. So decide where does he need to go, who needs to see him, what services need to be involved in his care. So we need to consult cardiothoracic surgery because we just put a chest tube in this guy. And then we also should consult pulmonary medicine. And this might be a potential ICU admission. So we have to kind of think about those things. Okay, so they did give us the pulse ox down here. It's 89. So we can try nasal cannula. If that doesn't improve, then we can move to a non-rebreather. So kind of like thinking, if this doesn't work, then what are we going to do next is really important in these cases. And then an EKG is going to be really important here too. So we want to take a look at his heart, make sure everything's okay there. He's not in any crazy arrhythmia that we need to fix also. Awesome. Do we need to manually order blood pressure tracking? That is a good question. Do we need to do that?
Yeah. So the vitals on this exam are really strange how it works. Like normally, when you admit a patient like to the floor, what you would do is put like for my patients that I admit to the pediatric floor, I have the nurses do vitals every 4 hours. So if you want vitals to be done at a certain interval and automatically pop up for you on the exam as that fake amount of time goes by, so say every 4 hours, which on the exam you can make go by in like 2 seconds. But you can order vitals every 4 hours, and that will give you a blood pressure with your vitals. The other way that you could, if you were really worried about somebody's blood pressure, so a patient that's septic and you're, titrating, epinephrine off of, their blood pressures, or, somebody who you're giving like numerous fluid boluses to, you can order, I think the order that you type in is continuous blood pressure monitoring. And it will, like, at any time that you want to see it, you can like click something that says like check blood pressure and it will pop up. So there's numerous ways to get your blood pressure frequently, but if you really wanted it to be like every 5 minutes, like how it would be in an ICU setting, you have to order the continuous blood pressure monitoring.
So that would be basically like an arterial line.
Yeah. Yep.
Nice. Okay. So after you put a chest tube in this patient, we have to get a chest x-ray to make sure that it's in the right place, that it didn't go through anything that it's not supposed to go through. So ordering a chest x-ray will finish this case. So you don't really have to manage him any further than this. You have to stabilize the life threat, call the important people, and confirm that your tube is in the right place. And that will end this case. And that's pretty much what ends this case in real life too. Like after this happens, the patient gets whisked away to surgery or the ICU and we are done. Counseling at the end of this case might be a little bit difficult to remember because this is, there's not really anything to counsel this patient on, so it's not super applicable to this one. But anything that you can think of, like for any of these patients, even if it's a critical one, like the API in the first case, still just mention it. Even if it's not something that you really would realistically have time to do in real life, just get those extra points. It's an exam, so just get the points. So just again, reading the history and the physical really carefully. So it would have been easy to miss any of those things in the physical exam because it is kind of a lot of text. So you do have to read a little bit, but just making sure that you're keying in on those important exam findings and just making a mental note to yourself. Don't delay care with unnecessary tests. So if this patient had come in and you had decided, okay, I'm going to get a bunch of labs first, and I'm going to do this, and I'm going to do this, I'm going to take a long history, like, you need to do the interventions that are important now, and you kind of have to select things in the order in which you would do them. So the needle thoracostomy, number one, then everything else comes after that, chest tube, and then everything else after. And then giving treatment quickly kind of goes along with that.
All right, so some kind of last minute pointers about these cases, and feel free if you have any specific questions, feel free to throw them in the chat. We'll use the last few minutes here anyway at the end. It's kind of like a Q&A. So, but some kind of big picture pointers for these cases. So this exam tests how the USMLE thinks you should manage this, which is not always how you do it at your hospital. Specific examples of this is like pre-op antibiotics. Every hospital does things a little bit differently. But however UWorld, when you're like going through these cases, tells you you should manage the perioperative antibiotics of appendicitis, like you should do it that way versus it doesn't matter what your hospital does. Again, kind of going off of that is that sometimes like in real life, like for example, the case that we just did, like that very much sounded like a pneumothorax. We did the needle decompression, patient gets better. If you did all of that and the patient is no longer having chest pain and, was doing better, you might not do in real life. You might not do some of the other things. But the point of this exam is to show that you have thought about the big differential, the big do not miss diagnoses, and you ordered all of the appropriate tests to rule out those things. So you don't need to go fishing for like those kind of like rare diagnoses. Make sure you've thought about, the big important ones. And then as long as you've ordered the tests for those, that's sufficient. Like I said, we've kind of emphasized this a lot, but doing every single UWorld case is a must, or getting the CCS cases from ccscases.com, but utilize those to your advantage. Look at every single one, think about every single one. Sometimes you'll find little like hidden gems of like things that you're supposed to do that you might not ever know that you were supposed to do had you not done the cases. A great example of that is if you're admitting a patient to the ICU, they probably deserve some prophylaxis for like GI prophylaxis, especially if they're on steroids. So you might want to start them on a PPI. They definitely need at least like your sequential compression devices to prevent DVTs. They might even qualify for Lovenox to prevent DVT. So things like that you just wouldn't even think of if you wouldn't have done these cases. So that's why it's really, really important to do every single one. The better you do on the easier cases, the more wiggle room you have on the harder ones. I will say if I remember correctly, there's 12 cases usually on your actual exam. And historically and anecdotally from everyone I've ever talked to, usually 11 of those, 10 or 11 of them are pretty darn straightforward, like the ones that we just did, where it's pretty obvious fairly quickly what the patient has. But there's usually one or two cases that it might be a little tricky to figure out what's going on, and you might actually have to wait for a lot of your labs or imaging to come back to have a diagnosis. But if you do really, really well on these slam dunk, MI, tension pneumo, cardiac tamponade, appendicitis, those types of things, then you have lots of wiggle room to, maybe have a case that doesn't go as well. And then definitely consider spacing out your exam. Like we talked about earlier, you can take your 2 days of step 3 up to 2 weeks apart. Most people, like I said, tend to take their first day and then give themselves a couple days and then take the second one. That's really, really great, especially if you're struggling with studying for cases, because then you can focus on multiple choice questions only on the first day, including your biostats, and then you can push that out of your mind and then spend the next couple days really just reviewing cases. I also like to make note of the cases that I think are really high yield or have a lot of information in them that I like easily forget. So for example, like I'm a pediatrician, so I don't see MI and heart failure that's managed in the same way as adults anymore. So those were ones that I'm like, oh, I should probably know this. And I kind of took note of those cases and I went back and looked at them in the days before my exam just to make sure I remembered all the little minute details that I don't use in my daily life as a pediatrician anymore.
So just to wrap up, some common mistakes that people make that we would love for you guys to avoid, not doing one full pass through UWorld. So UWorld is like the one and only resource you need aside from these cases. Like in terms of multiple choice questions, all you need is UWorld. There are other Q banks out there for sure. There's a lot of like video resources that people use. Some people even will try to bust out some of their old like step 2 resources. But chances are you're either going to be a busy resident or somebody who's busy trying to get into residency when you're taking this exam. So you really only have time to do the one gold standard resource that is considered to be the best, and that is UWorld. So make sure that you can get through UWorld at least once, maybe even finish all of your incorrects, or even better, get through the QBank one more time if you have the time. Versus trying to do like 4 or 5 different things and spreading yourself too thin and not being able to get all the way through the QBank and expose yourself to every single question. Don't be too overambitious with your study schedule, especially if you are in residency now and you're working while you're studying for this exam. I don't think there's any way that I could do more than like 40 questions a day for this exam, and that's on a good day. Like today was fine, but yesterday I got out of work like 2 hours late. I was doing a bunch of stuff. Like it's not realistic to think that you're going to get 80 questions done after a long work day, or that you're going to get up, 4 hours before your shift and do 80 questions. Like it's just not going to happen. It's not good for your wellness, and it's not good for you to have these unrealistic expectations of yourself, because you're just going to get let down and get frustrated. And we want you to be as realistic as possible. And that's definitely something that we can help you with at MST, is helping you create that realistic study schedule. And we use Cram Fighter for that as well. Overthinking the cases too much and focusing too much on that instead of focusing on questions can be another pitfall. So just making sure that you're getting through all of the questions is really, really important, because you have a whole day of questions and then a whole other half day of questions. So the questions are the majority of the exam. And if you know the material that's in the questions, chances are you'll do pretty well on the CCS cases. It's really just a matter of learning the software and kind of figuring out like what you need to click and how to navigate the actual interface. But once you figure out how to do that, it should be pretty straightforward. Ignoring your deficiencies. So if you are really, really terrible at biostats, like me, like I always forget this stuff because I don't use it in my daily life. So that's of course the first thing to go. But if you ignore that, then you're not going to get those points on the exam. And there's a lot of biostats on step 3. So really dedicating time to doing every single biostats question, maybe even twice, maybe even with your incorrects, like as many passes as you can get through that information, the better. Don't just focus on the questions that make you feel good because you know it really well. It's very tempting to do that. Like, I love cardio questions. I'm just going to do cardio all day and get them all right. That's not really helping you to improve and do your best on this exam. You got to focus on the things that you don't know so you can improve those areas and get better. And then pushing your test date back, we already kind of talked about this one a lot, but if you need to, sometimes life stuff happens. Sometimes there's a death in the family, or you get really sick, or, just like things happen. And in that case, it's totally okay to push your test date back. Very understandable. But if you don't really have a reason and you're just doing it because you're nervous or just worried that you're not going to perform that well, think again and just kind of reevaluate the situation, see what you can do to change your study methods or just like make some sort of change in the way that you're going about studying. But pushing back your test date is rarely the answer, and it's not necessarily going to get you a better score. It's just going to kind of prolong the stressful situation that you're currently in. So sticking to your date, picking a date at the beginning and sticking to it is really the best way to go.
All right. Now we're going to kind of open this up for a little bit of question and answer session. If you have any questions about anything, whether that be matching, interviewing, applications, step 3, we are open books, happy to help with anything. If not, it was really great talking with you guys tonight. We hope this was helpful for you. Really the biggest thing that I want to emphasize while we're waiting for some questions to roll in is that if you're struggling right now, this is a really tough time, especially for those of you who went through the match process and maybe didn't have the outcome you wanted. So if you're struggling, I really just wanted to emphasize, make sure you reach out to the people that are closest to you, that care about you, that love you, that are going to build you up. Not matching or failing a step exam or whatever it may be does not mean you're not going to be a great doctor. Those are individual, unfortunate things that are the part of this process to becoming a physician. But it doesn't mean you're not going to be a great one. So don't give up on yourself. We're not giving up on you. You guys are going to be successful. You're going to have a great career. You're going to help lots of patients. And at the end of the day, that's the most important thing. So if you're facing setbacks right now, this is not the end. There's lots of more great things to come. So keep your head up. And we are happy to help in any way that we can through these webinars, or if you want to do tutoring or anything, we are more than happy to help. I saw one question comes in that said, does most of our final score for step 3 come from the CCS portion or the multiple choice questions? This is like the mythical question that I don't think like we have a great answer to. Presumably, like, so when you get your score report, it doesn't tell you like, oh, like this percentage of your score is from your multiple choice, this is from your CCS cases. But presumably, since it's about a fourth of the exam, like of the time you take on the exam, presumably it's about a fourth of your score. Some people, like if you like read things online and speculate, some people think that it's a little bit more than that, even. because sometimes it can take up a little bit more than a fourth of that, or half of that last day of your exam. So probably somewhere between like a fourth and, I don't know, maybe a third of your score. So it's a big portion. I mean, that's a lot. So it gives you lots. If you can do really, really well in these cases, that also gives you wiggle room on your multiple choice questions too. So it's definitely worth investing the time in the cases, and they're actually kind of fun. Like once you get into them, like maybe I'm just a nerd and I kind of like them, but they actually can be kind of fun. So make sure you invest the time in it, because it is a decent portion of your score, even though we're not entirely sure exactly how much. Any other questions?
I don't see any other ones in the chat. Yeah, I think we're all set. Thank you guys so much for coming. I hope this was really helpful to you. I don't really have anything to add to Callie's wonderful statement that she just made. That was great. I wish you guys the best of luck wherever you're at in this journey, and you guys are all going to be great docs. If you're not there yet, you soon will be. So reach out if you have any questions, or if you would like some help with study planning, schedule planning, like any of that stuff, we'd be happy to help you guys.
Oh, there's one last question.
What are your opinions on step 3 before residency? I know a lot of people who did this and it went totally fine for them. So I think it's very doable. It just depends on kind of what your timeline is. Again, it's good to think about whether or not your program is going to pay for it for you or not, because that can potentially save you like $1,000. It's a pretty expensive test. And just how ready you feel for stuff like this that you're going to see on the test, like ordering things like GI prophylaxis and like DVT prophylaxis. Like if that's stuff that you've never seen before, it might be a little bit of a steeper learning curve for you, but you can certainly do it. You can just study it like anything else. So I think it's totally fine to do.
Yeah. And I will say too, I think a lot of people, it depends on like what specialty you're going into. So for example, like I went into pediatrics, and so all I see is kids now. And like I said earlier, like I don't see patients with MIs or, some of the more adult, like type 2 diabetes. Like I don't see that much. And so for me, like taking it even early on in my residency was important to me, because then at least internal medicine type topics and like OBGYN and things like that were closer in my mind. If you're planning on going into internal medicine or something that's a little bit more, or like emergency medicine, something a little more general, or even general surgery, it might not matter as much. But if you're doing like a more specialized, like either age group or like body system focused, like dermatology or something like that, it might be helpful to do it closer to graduation when you at least have thought about all those topics. And then the last kind of question was, will taking step 3 help the chances for getting into residency? I think it does. I think, and it kind of really depends. If this is your first time like applying to residency, and you don't really have any other kind of like red flags on your application, like, if your other board scores were okay and, you did okay on your med school exam, it definitely won't hurt as long as you do okay on it. But it might not help that much. But definitely if you applied this past cycle and didn't get a residency spot, I think it can only help you as long as you pass. So definitely, make sure you feel comfortable taking it and you're invested in the studying process of it. But if you feel confident that you can study and do well on it, it can only help you. I think it is something that really like kind of stands out on your application if that's already done. And that's something that we all have to do before we finish residency. Residency programs being able to check that box off for you, saying, oh, they've already done this, is helpful on their end. So I think it can only help you as long as you do well and make sure you pass. All right, you all. Thank you so much for being with us tonight. It was great talking with you all. Good luck with everything. And make sure to reach out to med school tutors if you have any questions or want any help from us on our end.
Thanks, guys.
Have a good night.